Okay, so now with the fluid control and electrolyte balance, we want to make sure that they have adequate hydration, and adequate hydration promotes perfusion and it decreases further brain injury. We want to manage increased intracranial pressure and use those interventions that we talked about when we discussed intracranial pressure, that will improve venous drainage. Overhydration may compromise perfusion by increasing cerebral edema. Adequate fluid intake during acute care via oral, IV, or tube feeding is a priority. Also monitor urine output to make sure the patient does not become dehydrated. If secretion of antidiuretic hormone increases in response to the stroke, urine output is going to decrease. So we have to look at that, because at that point, the patient will end up with fluid retention. Low serum sodium may occur. And if you got a low serum sodium, you got to monitor the patient for seizure activity. IV solutions with glucose and water are avoided because they are hypotonic and may further increase cerebral edema and increase intracranial pressure. Glycemic control should be maintained to avoid extreme hypo or hyperglycemia. In general, decisions regarding individualized fluid and electrolyte replacement therapy are based on the extent of intracranial edema, manifestations of increased intracranial pressure, central venous pressure levels, our CVP readings, electrolyte levels, and intake and output of the patient. Increased intracranial pressure is more likely to occur with hemorrhagic strokes, but can occur with ischemic strokes. Increased intracranial pressure from cerebral edema usually peaks in 72 hours and may cause brain herniation. Management of increased intracranial pressure includes practices that improves venous drainage, such as elevating the head of the bed, maintaining head and neck in alignment, and avoiding hip flexion. Additional measures for reduction of increased intracranial pressure include management of hypothermia. We want to keep their temperature between 96.8 to 98.6 degrees, which is 36 to 37 degrees C. Drug therapy to prevent seizures, pain management, avoidance of hypervolemia, fluid overload, too much volume, which we first talked about, overhydration, and we want to manage any constipation. And cerebral spinal fluid drainage may be used in some patients to reduce intracranial pressure. They also talk about the recombinant tissue plasminogen activator, which is that TPA. And I told you at Kindred we use Alteplase to try to get clots out of our PICC lines and our mid lines. But patients are screened carefully before TPA can be given. Screening includes a non-contrast CT or MRI scan to rule out hemorrhagic stroke, blood tests for coagulation disorders, and screening for recent history of GI bleeding, stroke, or head trauma within the past 3 months. Major surgery within 14 days or recent active internal bleeding within 22 days. And I know yesterday on the presentations I was telling you, before we start these blood clot busting medications, there is a screening that the patients have to go through to make sure that they meet criteria in order to receive that particular therapy. During infusion of the drug, the patient's vital signs and neurologic status are closely monitored to assess for improvements or for potential deterioration related to intracranial hemorrhage, cerebral rather, hemorrhage. We want to control the blood pressure. We want the systolic blood pressure to be less than 185 because that is critical during treatment and for 24 hours following intervention. Intra-arterial infusion of TPA may be used for patients with occlusions of the middle cerebral artery who can be treated within 6 hours of symptom onset. TPA produces localized fibrinolysis by binding to the fibrin in the thrombi. The thrombinolytic action of TPA occurs as the plasminogen is converted to plasmin, whose enzymatic action then digests the fibrin and fibrinogen, which actually breaks down the clot. Other fibrinolytic agents cannot be substituted for TPA. To be effective, intra-arterial TPA must be administered within 6 hours of the onset of stroke symptoms for patients with an ischemic stroke when mechanical thrombectomy is not an option. In the intra-arterial TPA procedure, the neurovascular specialist inserts a thin, flexible catheter into an artery, usually the femoral artery, and guides the catheter using angiogram to the area of the clot. The TPA is administered through the catheter and immediately targets the clot. Less TPA is needed when it is delivered directly to the clot, which can reduce the possibility of intracranial hemorrhage. Okay, we are only 7 minutes into this recording and it is 5:55. I am trying to go, I'm gonna try to go to 10 after 6. That'll give me at least 20 minutes to make it to Kindred. And as I said, I might have to finish this up with maybe 2 more presentations, but the ones that I do complete, I will upload those to CAMS. And tomorrow, when I get in here in the morning, I will look and see if that document finished exporting so that I can upload the spinal cord injury presentation that actually you can actually hear me talking on, versus just that upload that happened today. I was just so discouraged. But again, it's learning the system and how this really works. And I'm in hope that I have this down pat before we get to leadership and try to actually have it where we do feel like we in class and you can at least hear me or see me presenting the PowerPoint. So here we still talking about endovascular care. And let me see here. It says stent retrievers are becoming the most effective way of managing an ischemic stroke. Goals are the same as for the patient with the ischemic stroke when we talking about the care and management. But let me go back because I had a slide that I did not see. I'm sorry. Because I got some notes on a slide that I am not finding. I mentioned the use of these anticoagulants after, because I had, let me go back. So that fluid control. I talked about the TPA. I do. This next slide that I have following TPA, well, my actual notes that I have, why I do not have a slide that correlates with that, I don't know. But it talks about in the acute care that after the patient has stabilized and to prevent further clot formation. Patients with stroke caused by thrombi and emboli may be treated with the anticoagulants and platelet inhibitors, which we talked about those anticoagulants: aspirin, Ticlet, Pavix, Persantine. We talked about them anticoagulants: Xarelto, Warfarin, Pradaxa, Eliquis. We also talking about unfractionated heparin, which is our heparin drip, that they do that in the emergent phase following ischemic stroke. It says that the use of that heparin is generally not recommended because of the risk for intracranial hemorrhage. They want you to do aspirin, which we talked about the dose being 81 to 325 milligrams. That may be initiated within the first 24 to 48 hours after the onset of ischemic stroke. And complications of aspirin with higher doses include GI bleeding, and aspirin administration should be done cautiously if the patient has a history of peptic ulcer disease. So now we are on the stent retrievers becoming the most effective way of managing ischemic stroke. And they got an example of a stent retriever called a Solitaire FR. That's a way of opening a blocked artery in the brain by using a removable stent system. During the procedure, a catheter is used to guide the small stent from the femoral artery in the groin area to the affected artery in the brain. The stent is guided using neuroimaging into the part of the artery where a blood clot has formed. The stent expands the inferior wall of the artery and allows flow to get to the patient's brain immediately to prevent as much brain damage as possible. The clot seeps into the mesh of the stent, and then after a few minutes, the stent and the clot are removed together. Stent retrievers, again, are becoming the most effective way of managing ischemic stroke. And the en-route device accesses the carotid arteries through the neck rather than the groin. The en-route uses a blood flow reversal system to capture pieces of the blockage dislodged during stenting procedures. And while it also maintains blood flow to the brain. So talking about these stent retrievers, you got the Solitaire FR and the en-route device, and they are becoming the most effective way of managing ischemic stroke. So again, same things we're gonna look at: airway management, our A, B, C's. We're going to look at management of intracranial pressure. We also going to look at the anticoagulants and platelet inhibitors in relationship to a hemorrhagic stroke. These are contraindicated. We want to do management of the hypertension, oral and IV agents to use, treat the blood pressure. We're going to do seizure prophylaxis in situations where it is deemed necessary. It says that seizure prophylaxis in the acute period after intracerebral and subarachnoid hemorrhages is situation specific and should be discussed with the interprofessional team. Then we talk about the surgical interventions for hemorrhagic stroke include immediate evacuation of aneurysm-induced hematomas or cerebellar hematomas that are larger than 3 centimeters. Individuals who have a AV malformation or arteriovenous malformation, we call it an AVM, may experience a hemorrhagic stroke if the AV malformation ruptures. The treatment of AVM is surgical resection and or radiosurgery using a gamma knife. Both may be preceded by interventional neuroradiology to embolize the blood vessel that may supply the actual atriovenous malfunction. They talking about clipping and wrapping of aneurysms. That is a berry aneurysm. In a subarachnoid hemorrhage, bleeding from a damaged vessel causes blood to accumulate between the brain and skull. The leaked blood can irritate, damage, or destroy the surrounding brain cell. When blood enters the subarachnoid space, it mixes with the cerebrospinal fluid. This can block cerebrospinal fluid circulation, thus causing increased pressure on the brain. The open spaces in the brain, which are the ventricles, may enlarge, resulting in hydrocephalus. This further increases intracranial pressure due to the large accumulation of blood and can result in further brain damage. Insertion of that ventriculostomy drain for cerebrospinal fluid drainage can dramatically improve these situations by reducing intracranial pressure. Goals for managing intracranial pressure are the same for patients with a subarachnoid hemorrhage as they are for patients dealing with an acute stroke. Subarachnoid hemorrhage, usually caused by a ruptured aneurysm. That's what usually causes it. And patients may have multiple aneurysms, and treatment of an aneurysm involves clipping or coiling the aneurysm to prevent rebleeding. And clipping of the aneurysm involves the neurosurgeon placing a metal clip or metallic clip on the neck of the aneurysm to block blood flow and prevent rupture, and the clip actually remains in place for life. Okay, it is 6:04. I'm gonna roll on as long as I can, and that's showing a GDC coil. And in A, that is a hydrogel coated platinum coil that is used to occlude an aneurysm. The softness of the platinum allows the coil to assume the shape of irregularly shaped aneurysms while posing little threat of rupture of the aneurysm. In illustration B, a catheter is inserted through an introducer, which is a small tube, in an artery in the leg. The catheter is threaded up to the cerebral blood vessels. In illustration C, the platinum coils attached to a thin wire. They are inserted into the catheter and then placed in the aneurysm until the aneurysm is filled with coils. Packing the aneurysm with coils prevents the blood from circulating through the aneurysm, whereby reducing the risk of rupture. And eventually a thrombus forms within the aneurysm, and the aneurysm becomes sealed off from the parent vessel by the formation of an endothelialized layer of connective tissue. So in our hyperdynamic phase of therapy, after aneurysmal occlusion via clipping or coiling, hyperdynamic therapy, which is hemodilution-induced hypertension using vasoconstricting agents like the phenylephrine, which is the neosynephrine, or dopamine, or you can induce hypervolemia. They may be substituted in an effort to increase the mean arterial pressure and increase cerebral perfusion. Volume expansion is achieved using crystalloid or colloid solutions. Interventions to treat cerebral vasospasm either before or during aneurysm clipping or coiling include administration of calcium channel blocker, Nimbotop, I guess. Nimodipine is the other name, but it's Nimotop, which is given to patients with a oh my God, I'm getting tongue-tied. I'm trying to rush because I know I got to go to work. I'm sorry. Subarachnoid hemorrhage to decrease the effects of vasospasms and minimize cerebral damage. The Nimotop drug that restricts the influx of calcium ions into the cell, whereby reducing the number of open calcium channels. They are not really sure how exactly this calcium channel blocker mechanism of action does reduce vasospasms. They don't really quite understand how it does it, but it does. Subarachnoid and intercerebral hemorrhage can involve bleeding into the ventricle of the brain, and this situation can induce hydrocephalus, which further damages brain tissue from increased intracranial pressure. And insertion of a ventriculostomy for cerebral spinal fluid drainage can result in, again, dramatic improvement in these situations. I got a couple of, well, I do have a case study question, and I am going to end this presentation with this question, and I will start another presentation that is going to talk about, well, maybe let me finish this one up with before I start nursing assessment. I'm gonna try to finish this up with these last 3 slides. Okay, we got another case study question. PD is diagnosed with a thrombolytic stroke. Over the next 72 hours, you plan care with the knowledge that he, one, or A, is already for aggressive rehabilitation, B, will show gradual improvement of the initial neurologic deficits, C, may show signs of deteriorating neurologic function as cerebral edema increases, or D, should not be turned or exercised to prevent extension of the thrombus and increase neurologic deficits. That is PD, who is diagnosed with a thrombotic stroke. Over the next 72 hours, your plan of care is based on the knowledge that he, A, B, C, or D. I'll look for the answer for that. And then it has, let's see, did I speak on that hyperdynamic therapy? Yes, I did. Next, it had this rehabilitation phase, that after the stroke has stabilized for 12 to 24 hours, interprofessional care shifts from preserving life to lessening disability and attaining optimal function. So that patient may be transferred to a rehab unit, outpatient therapy, or home care-based rehabilitation. And then the last of this particular presentation is going to be the core measures for stroke. And if you look in table 57-8 in your textbook, it has listed there the core measures for stroke. Is called the STK stroke measure set is there. And it says that the stroke core measures were developed in partnership with the American Heart Association and is used by primary stroke centers. These core measures are used by hospitals for acceleration and certification, and measures are implemented during the hospital admission and prior to discharge, and aligned with guidelines supported by the American Heart Association. Get with the guidelines is called GWTG, Stroke Patient Management Tool, and the Centers for Disease Control and Prevention, which is the CDC, as well as the National Acute Stroke Registry, and that is abbreviated the PCNA. ASR. So I will end this presentation with that, and I will start the last of it talking about the nursing management, starting with the nursing process or nursing assessment. Thank you.